right, so we'll go ahead and move into the first section, which is on modern multimodal analgesia. So some big words, but what we're talking about is that pain management is an issue with our athletes. And I'm going to talk initially about the pain management around the surgical procedures that we do. And then Chris is going to talk to you about the pain management from the locker room. And then we'll have a panel discussion on what are some of the ideas from some of the people that are right there on the ground trying to take care of these athletes and get them back into the game when they know they have pain, and they're going to try to play through that, and what are some of the strategies that we can use. So again, I'm going to speak initially about the surgical management with regards to pain. And there's been a number of advances, and I think you all are aware of, with regards to people you know that have had surgery and how more and more procedures are being done in an outpatient setting, and that's going to continue to grow dramatically. These are my disclosures, which again are updated regularly on the American Academy of Orthopedic Surgery website. Pain is an unpleasant sensory and emotional experience associated with actual tissue damage in the majority of cases. Acute pain comes right at the time of surgery, and chronic pain 3 months later. Just watching that incision, you start to feel a little bit of pain and realize that that could be very uncomfortable. And even before we get to the operating room, we've realized, and I'm sure you've seen in the press lately, we have a huge problem with the misuse of our narcotic and opioid medication in this country. And this country in particular is much greater than most of the rest of the world in terms of the abuse and misuse of opioids by our patients. They're readily available. They're given frequently by lots of different sources, and many times our patients don't share with us that they have this problem. And as you see here, when you look at surveys of individuals, it's our younger patients that really have the biggest problem. And we see this even in our teenagers now, and there's more and more information coming out on pediatric abuse of opioids and programs related to that, which is really scary. So we have to think about how we can get away from opioids as a pain management strategy, because it's not really working the way we'd like. So if we understand a little bit more about how pain is generated, and there are some very sophisticated models for this, and I'm not going to go through the whole process, but obviously there's these afferent nerve fibers that come into this area, and then when we do surgery, there's a signal that's sent in there, and then you get a tissue response, and you start to get a shifting of a variety of different nutrients and proteins that cause signals to go to a variety of different places. Like nitrous oxide will then go as secondary messengers and cause all sorts of things to happen and cause hyperexcitability and toxicity in the surrounding area, which then releases more of this and gets back into the nerves and then goes up to the spinal cord and into our brain and says, wow, that really hurts. And so this can go in a variety of different areas, and when we understand these pathways, we can then come up with strategies on how to prevent this. So the COX-2 inhibitors you see here, and a variety of prostaglandin management processes that have been in place, because these are a major mediator in terms of sending the signals related to pain. And then once the damage occurs, then there's this ongoing process that continues to send off the nitric oxide, the prostaglandins, and a variety of different things. And so we start to get some ideas about where we can block this so that we can prevent those signals from getting into the nerves, getting into the spinal cord, and being transmitted to our brain, where we feel all the symptoms that are going on. And so it's a very complex way of thinking about things, but we understand that there's a lot of surgeries done in the United States alone, 73 million a year. And if you ask patients if it hurts, what they will tell you is 80% of them say, even with medication, that they experience anywhere from moderate to extreme pain. So we do have the ability to recognize this, and now we have to have the ability to kind of treat that better. And if we understand that once we make this incision on the skin, that there's signals that are sent to a variety of different areas and go into our spinal cord and then up into our brain, we can figure out ways to work around preventing this transmission of pain. And this happens right at the site of the surgery. It happens in the way that it's transmitted to the spinal cord, and then the way that it's transmitted to the brain. So this whole area of multimodal analgesia is a combination of different analgesics that act by different mechanisms, resulting in additive or synergistic analgesia with lowered adverse effects. compared to sole administration of an individual pharmacological agent. Instead of just giving heavy doses of narcotic, we're trying to block it with a variety of different medications at different levels. And this occurs at the time of surgery, but we're using this also more often in the outpatient non-surgical setting. So we want to minimize that pain with the preemptive strategy. So even in the holding area, our patients will oftentimes get a cocktail of medication. Lyrica or pregabalin is helpful. A non-steroidal is helpful. Acetaminophen is helpful. And then a scopolamine patch to manage their nausea. And this has been shown that a variety of these medicines like Lyrica can be quite helpful in potentiating the variety of different effects of these medications. Injectable acetaminophen has been available in the United States for a little bit less than a decade, but it's been available in Europe for more than 20 years. And this seems to be also a useful adjunct. It's expensive, but it's helpful. And we in the upper extremity world use interscaling, supraclavicular, and axillary blocks quite regularly because this preemptive analgesia, the patients don't feel pain till well after the surgery, and this works out very nicely. These local the anesthetics work well to block the signals so they don't even get to the spinal cord and get into our brain, and the patients can have a much better experience. 10 years ago when we did these, we were very worried about the way this was done is you put the needle in until the nerves jump. They had a little nerve stimulator on it, and sometimes if you had less experienced people, they would damage the nerve. And so you'd have people with residual effects, and there was a number of complications that were frustrating to deal with, and this really got a bad name in a variety of different areas. Well, ultrasound changed all of that. Once our anesthesiologists could see exactly where the needle needed to go, many of them became experts at doing this. And if we see this model here, we look for these little circles, that's where the nerves are coming in through the scalene muscles, and this is up in the neck area. And this is what you can see on the ultrasound. You know if you put that needle very close to this area and you inject the fluid, it works out great. So here's a patient who's wide awake that has an open screen in front of them. There is the ultrasound device across the room from them, and we can start to see the little circles right here, and we know that's where the neurovascular structures, the neurologic structures are, and you see the needle coming in right there. And you can watch that coming in without poking the nerve. You can actually come right to the sheath and go right in place, and then once you have that needle lined up exactly where you want, and the anesthesiologist is sure that he's in a good spot, then he can inject the fluid. And this has increased the successful rate of these to well over 97% in most studies, and the complication rates have been dramatically reduced. This is done now with femoral nerve blocks and lots of other places, and ultrasound has made a huge difference in making this a very safe procedure. One of the places that's been a pioneer in this almost 10 years ago wrote about using ultrasound as part of their way of doing this was out at the University of Utah, and many other places now have adapted this as their standard of care. There are some complications. If you put too much in, there can be cardiac or neurologic issues. Rarely people have an allergic, and you can have some people get a lot of swelling. The benefits are very clear. The patients don't feel any pain before or after the surgery. They're able to leave the surgery center and get into a comfortable position, and then we manage their pain after that. There are some few contraindications. Of course, the patient refuses to have it, or if there's an infection, or if they truly have an allergy, which is quite rare. And there's also the new medication. So there were some concerns about these regional blocks. And so this company, Pacira, developed this medication called Exparel, which is a lysosomal bupivacaine. And you may hear a lot about this because they've done a great job of marketing to the public and the patients. But basically what it is this local anesthetic, which is long-acting, is buried into these lysosomes, so they have a slow release. And because of that, the effect of this can be quite substantial for an extended period of time. And this medication has been used successfully with total joint replacement like hips and knees, and sometimes in total shoulders, some recent reports, and some of the other things that people are doing. But it's definitely gaining a lot of popularity, and you see more and more people talking about it. And here's from their website where they actually tell you to talk to your doctor about managing your post-surgical needs. So physicians in the audience may hear them come to you and say, hey, do you use this? And if you don't, why not? And it even tells you to keep your doctor informed. So there's a lot of information here to know about these kind of things. Now, once we've got this all protected, we still use a little bit of narcotic, and we've got to protect them from the nausea. You know, when people are sleepy and they're nauseated after surgery, it's from the narcotic typically. And so we use a cocktail of medication to try to prevent the nausea. And then the discharge medications, you see it's a lot of them, but it's just a little bit of a lot of them. So the oxycodone, of course, a narcotic, and then a non-steroidal, and then the Lyrica, and then a medication to stabilize their nausea, as well as soften their stools, and then some aspirin. And it's amazing how smooth the process can be for these patients. We do now our total hips, our total knees, our total shoulders, big operations, spine surgeries, and of course all the sports medicine surgeries on an outpatient basis. Patients are given very specific instructions how to do this. The cost has been dramatically reduced by using these types of multimodal analgesia effects in terms of the patient management and what they require in medicines, and we hope this will also help us with this opioid epidemic that we're seeing in the United States. And our pain management specialists and anesthesiologists are on board as our partners to try to help us out with that, and that makes a big difference. And that also helps when you're looking at things like patient satisfaction. You see the scores going up dramatically in inpatient as well as outpatient settings. So this is what we're doing in 2016 in terms of our management for patients that are undergoing surgery. It's a multimodal approach. Preoperative intervention, we use a lot of blocks or the Exparel type medication, and then we have a very specific protocol for postoperative medication, and this has made the surgical management of our patients much more effective, much higher patient satisfaction, and has made both our lives and their lives easier. Thank you very much.